On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Wrong Site Surgery Prevention Using Interprofessional Collaboration to Improve Outcomes. My name is Kelly Gibson, and I'll be your moderator for this program. Now I'd like to introduce our speakers for the webinar. Robert Yanish, a registered nurse, has been with the Patient Safety Authority since 2009 as the Patient Safety Liaison for the Southwest region of Pennsylvania. In his role as a Patient Safety Liaison, he is responsible for working with his regional medical facilities to assist them in the reduction and elimination of medical errors. In this position, Robert has been assigned to a number of projects, including the statewide CMS Partnership for Patient Hospital Engagement Network, Wrong Site Surgery Prevention Collaboration, and the Pennsylvania Patient Safety Authority, Pennsylvania Society of Anesthesiologists, Wrong Site Block Initiative. Robert is a member of the American Society of Professionals in Patient Safety and has attained certification as a certified professional in patient safety and certified Six Sigma Lean Green Belt in healthcare. He is also a master trainer in team steps. Our second speaker is Lori Bickerstaff, a patient safety officer for Excela Health System. She received her Master of Science in Health Services Leadership from St. Vincent College. During her 28 years in nursing, she has served in many roles, including nurse manager. She has completed the Johns Hopkins Patient Safety Certificate Program and is a member of the National Patient Safety Foundation. Throughout her healthcare profession, she has been involved in many quality improvement and patient safety initiatives. Our third speaker, Jennifer Gregory, Patient Safety Officer for Excela Health System in Western Pennsylvania. Jennifer earned her baccalaureate nursing degree from Pennsylvania State University and is a graduate student at Walden University pursuing a master's degree in nursing with an emphasis in leadership and management. She has served in many roles in nursing, including critical care, managerial, and quality improvement. Jennifer is a certified professional in patient safety and is a member of many professional organizations, including the National Patient Safety Foundation, American Nurses Association, and the Pennsylvania State Nurses Association. Bob, I'll turn the program over to you.
Thanks, Kelly, and I'd like to thank everyone for taking the time out of your busy schedules today to join us as we review the topic of wrong site surgery in the Commonwealth of Pennsylvania. We'll also review the efforts by my colleagues and I at the Patient Safety Authority to prevent these events from both occurring by aggregation of the data that we receive, as well as educative and collaborative efforts with statewide associations and individual health systems, as well as facilities. When we set up this webinar, my goal was not only to provide you with an overview of wrong site surgery events, but to let you hear firsthand from individuals on the front line who have collaboration with the authority made changes to prevent future events. Today we have with us two patient safety officers from the Excela Health System to share the story of their system-wide collaboration and commitment to eliminate wrong site events. At the conclusion of today's webinar, our objectives are that you will recognize that wrong site surgery events continue to be a threat to patient safety, that you'll be able to describe the role interprofessional collaboration plays in the prevention of wrong site surgery, that you'll be able to identify how a safety culture and teamwork impact patient safety in an organization, and also recognize the necessary components of a continuous improvement project that will result in sustainable outcomes. So to start our presentation, we really need to ask the question, what exactly is wrong site surgery? When we use the term wrong site surgery, we include all surgical procedures performed on the wrong patient, wrong body part, the wrong side of the body, wrong level, as in spinal cases, also wrong procedures. Consistent with the National Quality Forum's definition, surgery begins, regardless of setting, at the point of surgical incision, tissue puncture, or the insertion of an instrument into tissues, cavities, or organs. Now, wrong site surgery also occurs if a procedure begins at the wrong site and is then corrected. An example of this would be if staff discovered after starting surgery that an incision was made on the wrong side. They closed that wound and then proceeded to complete the surgery on the correct side. According to the definition of a surgery beginning at the point of surgical incision, this still would be a wrong site surgery. The terms also includes areas outside the actual operating room where anesthetic blocks or pain management procedures are performed. Now, this in a large facility may be a dedicated block room or simply in the pre- and post-operative areas of a hospital. For those of us who have been in patient safety, we know that wrong site surgery has consistently been an issue over the years, not only here in Pennsylvania, but throughout the nation and actually worldwide. Entities such as the Joint Commission, National Quality Forum, the Centers for Medicare and Medicaid Services, as well as the World Health Organization have addressed wrong site surgeries with recommendations and best practices. The Joint Commission considers wrong site surgeries as sentinel events and includes them in their national patient safety goals. The National Quality Forum considers those as never events. CMS announced actually in 2009, February actually, that facilities would not be reimbursed for any cost related to these events. In the Commonwealth of Pennsylvania, event reporting in hospitals, ambulatory surgical facilities, birthing centers, abortion facilities has been mandatory since June 2004 as per Act 13 of 2002, better known as the MCARE Act. Events are sent to the authority utilizing the Pennsylvania Patient Safety Reporting System, which many of you have come to know as PA PACERS, where our staff analyze the data, we identify trends, and make recommendations to reduce the number of future events. Review of these event reports beginning in July of 2004 reveals that there have been 731 wrong site surgeries reported to the Pennsylvania Patient Safety Authority through December 2016, an average of one wrong site surgery reported per week in Pennsylvania. As you can see in this slide, wrong site surgeries hit an all-time high in the 2007-2008 academic year, with 76 events reported. In the second and third calendar quarters of 2015, there was an increase in events with 21 wrong site surgeries reported in each of the quarters. When we drill down the event data, we find that wrong site anesthetic blocks and pain management procedures make up approximately 38% of the total wrong site surgeries reported to the authority. This slide shows the three most common types of wrong site procedures reported through PA PACER since July 2004 have remained consistent, and they account for about 50% of all wrong site surgery events. In the December edition of the authority's Patient Safety Advisory, results from an analysis of wrong site surgery events from July 2004 through December 2016 occurring in ambulatory surgical facilities was published. This revealed an increase in events over time. The study identified that approximately 29% of all wrong site surgery events were reported by ambulatory surgical facilities. This translates to about one event every 3 weeks. The authorities developed 21 evidence-based principles to prevent wrong site surgery. Now, these recommendations are based on a number of things. The detailed analysis done by the authority on the causes of wrong site surgeries in the operating room areas, the best practices associated with avoiding wrong site surgeries and catching these errors before they harm patients, and the effective strategies for reducing wrong site surgeries in the operating room areas. Now, these recommendations are intended to enhance and not conflict with the Joint Commission's Universal Protocol, reducing wrong site surgeries in the OR areas. Now, the evidence-based principles, along with a multitude of other resources related to the prevention of wrong site surgery, are actually available on the Patient Safety Authority homepage. Here in this slide, you'll see a screenshot of the newly refreshed website that was just launched in the past week. The site's located on the web at www.patientsafety.pa.gov. Now, the educational resources can be found by clicking on the highlighted patient safety topic link located on the top of the homepage, actually shown here and circled in red. When you click on that link, you'll be given a number of choices, including wrong site surgery, which will take you to a topic overview. If you look on the left side of the page, you'll see a number of subheadings, including the key data and statistics page, shown here, which houses the principles for reliable performance of correct site surgery, plus other key data as you scroll down the page. Another subheading is a listing of educational tools related to the prevention of wrong site surgery. Included here, you'll find a gap analysis and action plan to prevent wrong site surgery, a number of self-assessment checklists to evaluate and monitor your programs. There are educational posters, there are brochures, and much more. Also included is a link to multimedia presentations on the subject of wrong site surgery. This page includes a number of short video clips and presentations that can be used in your staff educational efforts. Since 2007, the Patient Safety Authority has been joining hospitals, health systems, as well as professional organizations in a collaborative effort to eliminate wrong site surgeries. Most recently, Authority staff and physicians from the Pennsylvania Society of Anesthesiologists have been working together to address the prevention of wrong site anesthesia nerve blocks. Because about 1/4 of all wrong site procedures are attributed to the wrong site nerve blocks, the goal of this collaborative effort is to develop practical and relevant clinical guidelines for physicians, nurses, and healthcare facilities statewide, and actually to update current Authority resources. Authority staff are also available to assist individual Pennsylvania facilities and health systems with wrong site surgery prevention consultations. These consults can be done proactively in response to a near-miss event, or to assist staff following an event by both by either in person, or we can do those by phone. The Authority staff are also available to conduct on-site observations and evaluation of facility compliance and practices related to those evidence-based best practices to prevent wrong site surgery. These visits can include observations, starting out in the preoperative area and then continuing through to the operating room, as well as policy review and interviews with your staff. The Authority has conducted many consultative visits throughout the years with excellent feedback from facility staff in both the hospital and ambulatory surgical setting. Lastly, the Authority patient safety liaisons are available to prevent educational sessions on the topic of wrong site surgery prevention for both facility staff and organizations. If you'd like to discuss a consultative visit at your facility, please contact your regional patient safety liaison. This makes actually a nice transition into our speakers. Today I thought it'd be helpful to allow one health system that actually sought a consult from the Authority to tell their story. The Excela Health System has been working with the Pennsylvania Patient Safety Authority for a number of years on a variety of projects. One of these projects included a consult with Authority staff to address the issue of updating their system-wide universal protocol policy. Here today from the Excela Health System are their patient safety officers, Lori Bickerstaff and Jennifer Gregory. Lori, I'll hand it over to you.
Thank you, Bob. Good afternoon. At this time, Jennifer and I would like to thank all of you for joining us, and a special thanks to the Patient Safety Authority for allowing us to speak to you about wrong site surgery prevention using interprofessional collaboration. First, I'd like to tell you a little bit about Excela Health. It was established in 2004 and is located in Westmoreland County. It is a non-for-profit health organization that includes 3 licensed acute care hospitals, 2 freestanding outpatient surgery centers, home care and hospice, physician practices, a durable medical equipment company, and other facilities and services. The organization is governed by a board of trustees made up of a diverse and respected group of community leaders. Excela Health currently has a medical staff consisting of 735 physicians and allied health professionals, along with more than 4,900 employees. At Excela Health, our mission is to improve the health and well-being of every life we touch. Excela Health strives to be a high-quality, valued-driven community health and wellness system. We manage the health of our population proactively. Our caregivers and community work together to prevent and manage disease with early detection. We improve continuously through education, communication, and effective management. We put our patients first. We have a passion for quality, we care about people, and we work as a team. We act with the highest level of integrity and honesty and are good stewards of our finances and resources. So the reason we're here today is to talk about the prevention of wrong site surgery. At Excela Health, we perform approximately 18,440 surgical cases a year. And even though wrong site surgery is considered a rare event, as Bob said, one occurs a week in the state of Pennsylvania. And as you can see, Excela Health was not exempt. From fiscal year 2009 to fiscal year 2011, we did work with revising our policies and establishing standard work to prevent wrong site surgeries from occurring. It seemed like it worked. In fiscal year 2012, we saw a decrease to 1 wrong site surgery and 0 in fiscal year 2013 and fiscal year 2014. Did this create a false sense of security that it would never happen to us again? As you can see, the assumption was wrong. So where do we begin? We had already revised our policies and established standard work. And as we learn in Lean 101, standard work improves quality and reduces errors and waste. In our case, we had experienced a period of success with 0 wrong site surgeries. So what had changed? Was the standard work we established not being followed, or did things change that made the standard work ineffective? We knew we were not going to understand why things were happening unless we asked, listened, and observed our team to know what barriers they were experiencing, what changes would need to be made, and how we were going to accomplish them. The concept of change management is familiar today, but how we manage change varies enormously depending on the organization, the people involved, and the changes being implemented. Using Kurt Lewin's simple and easy framework for managing change, unfreeze, change, and freeze, taking that block of ice, changing it, and reforming it into a cone of ice. We had to start the unfreeze with the motivation to change existing attitudes towards work practices. That old saying, "We've always done it this way," had to go away. We then moved through the change process by effective communication and empowering the team to embrace the new ways, the values, and the behaviors. And finally, the freeze, the sense of stability. The reinforcement of the change occurred through supportive mechanisms, policies, structured, and ongoing monitoring. This is a timeline of our journey beginning at the end of fiscal year 2015. At Excela Health, there were 2 reported wrong site procedures within a 2-month period. On the timeline, it looks like both occurred in fiscal year 2015, but actually the second one occurred in July of 2015, which is fiscal year 2016. One occurred in the operating room, and one occurred in the interventional radiology department. Excela Health had not experienced a wrong site surgery since July of 2011. As patient safety officers, we knew that wrong site surgeries were a complicated problem and were not to easily be solved. So with the support of Excela Health leadership, and especially the perioperative leadership, we reached out to the Pennsylvania Patient Safety Authority for help. We all know that change takes time, and while we were working through our changes, we experienced 3 more wrong site surgeries. 2 occurring in the operating room and 1 in the interventional radiology department, involving wrong side and wrong level procedures. So the patient safety officers arranged for the Pennsylvania Patient Safety Authority to come to Excela Health to provide awareness, beginning with our leadership, our physicians, and our frontline staff. Over 150 Excela Health employees attended the educational sessions that included wrong site surgery occurrences and some examples of actual cases that had occurred. In addition, the tools and strategies were shared for the prevention of wrong site surgery. Again, with the support of Excela Health's Vice President of Peri-Op Service and her leadership team, the patient safety officers networked with the Pennsylvania Patient Safety Authority Wrong Site Surgery team. Dr. Teresa Arnold, Clinical Analysis for the Pennsylvania Patient Safety Authority, and Bob Yonish, Patient Safety Liaison for Southwestern Pennsylvania, to conduct an on-site organizational risk assessment to evaluate and compare Excela Health's current practices with the 21 evidence-based practice recommendations to reduce wrong site surgery by performing 23 observations in our operating rooms, in interventional radiology, and the Heart Center. The team was able then to provide real-time feedback to the staff that was involved. I would like to take a minute at this time to acknowledge the openness of the staff that attended the educational sessions and were observed during their work. They willingly shared their experiences, their concerns, and asked questions that later helped to direct our wrong site surgery reduction plan. After initial debriefing, and with the help of the Pennsylvania Safety Authority Wrong Site Surgery team, we took what we observed and the 21 evidence-based practice recommendations to reduce the wrong site surgery and compared and developed a gap analysis. We saw that our process was not standardized across the system. Two areas that we found became clear to us. First, our process. In our process, we needed to look at our pre-procedure verification. Were all the relevant documents available? Were they complete? And were they correct? There were issues around site marking. Where should it occur? Did we have a standardized set of site marking rules? And actually, what marking were we going to use for the site? And finally, timeout, specifically the hard stop. What needed to take place when anesthesia procedures or multiple procedures occurred? And what did we do about radiological confirmation? The second area we found that needed some opportunity for improvement was teamwork. Everyone involved in the procedure needed to be part of the team with assigned duties for specific team members. Now I'm going to turn it over to Jennifer to discuss the changes we made.
Thank you, Lori. When Lori and I were asked to share the work our organization has been doing to reduce the risks of wrong site surgeries, an African proverb came to mind that I felt summed up our journey. It states, if you want to go fast, go alone. If you want to go far, go together. We know that despite efforts to eliminate wrong site surgeries, they still continue to occur. So we were going to be in this for the long haul, and in order to be successful in reducing the risks of wrong site surgeries, we would need the knowledge and skills of multiple professionals who all share a common goal, and that goal was to reduce wrong site surgeries. Our interprofessional task force consisted of frontline perioperative staff from across our system, departmental chairs of surgery and anesthesia, vice president and direct managers of our surgical services, our chief medical officer, and quality and educational personnel. The knowledge each member brought to the table was instrumental in defining standard work. They are now the champions to support the culture of safety and they utilize a continuous cycle of improvement to proactively prevent wrong site surgery. So let's talk about some of the changes we made to our system-wide universal protocol. First off, we used the gap analysis that Lori talked about as a framework to guide the work of the task force. And to give a little bit of context to the slide, our existing policy had been created right around 2002, 2003, and this was right around the time the National Patient Safety Goal to reduce wrong site surgeries was introduced by the Joint Commission. And over time, additions have been made to our policy when events happened, and it became very lengthy, and according to our frontline providers, it allowed variances to occur in practice because it was so complex. And if they had a question, they could not find the answer within the policy. And also that key portions of the universal protocol lacked defined process owners. So after many discussions and many meetings with our interprofessional team, a revised policy was created that reflected current workflow and also met regulatory standards. We will be discussing these changes in greater depth in the upcoming slides, but the major highlights include standardizing site marks used by surgeons in anesthesia, assigning ownership to initiate the timeout, and also defining the expectation of a hard stop during the timeout process. So why is teamwork training so important? Well, when you look at the universal protocol, it really involves active communication among providers, along with communication between providers and the patient. Excela currently has a teamwork training program that was developed utilizing the evidence-based framework of team steps. We identify the need to reinforce attendance from the perioperative group during our risk analysis, and also our leadership team ensured that staff were able to attend by providing the resources to cover shifts. Our teamwork program does focus on creating interprofessional approach to transform team behaviors. It is taught by our frontline staff, and it equips staff with the tools and strategies to enhance collaboration, coordination, and communication within and across our teams. By training staff to communicate clearly and respectfully, this creates an environment that empowers staff to speak up, and tools like huddles and briefings serve to connect the team to the patient by outlining a plan, next steps, and potential risks to our patients. The debriefing connects teamwork to improvement and performance by evaluating what went well and what we could have done better. Well, we knew from our past experience that to reduce the risk of wrong site surgeries, we were going to need to do a lot more than just revise the policy and send it out for staff to review and then sign off. What we needed to do was incorporate some innovative teaching methods. And, learning is the first step to change, and learning from others' mistakes allows organizations like ours to prevent similar events from occurring. Some ways we've incorporated learning from others into our structure include having the Pennsylvania Safety Authority come in and do observations in all of our operative areas, and then providing feedback of ways we could improve our process. We also have them come in and do interprofessional educational updates on wrong site surgeries in Pennsylvania that is occurring annually, and the causes surrounding them. Also at Excela, we are being transparent about our near-miss events, and we're sharing lessons learned with the whole team across all of our different campuses. Our perioperative educators have done a really great job. This year, they did create interprofessional simulation events that reviews specific key pieces of our universal protocol that need to be verified. So for an example, the circulators have to check a mock patient chart for our documentation. The team demonstrates a effective timeout. We have stations where things were intentionally wrong, and it required our staff to demonstrate how they would communicate or correct the issue using some of the tools and strategies that were taught in our team training programs. Also, we've incorporated some observations of our surgical teams in real time. These are conducted by our quality and also our clinical nurse coordinators of the operating rooms, and we do provide feedback just in time or after the case, and the whole team does learn from the improvements. We also have annual education and departmental talks about reporting of events, and we complete safety rounding to interact with our frontline staff to promote proactive reporting. So what did we change or reinforce in our pre-procedural verification process? Well, first, we made it the expectation that specific information is available for verification on reference documentation. This includes procedure, site, laterality if indicated, and are consistent with the patient and team's expectations of the intended procedure and site. The patient cannot enter the operating room if there are any discrepancies in the reference documentation. They are held in our preoperative rooms until we have that clarified. We also reinforce that verbal verification is done with the patient and family and should be completed using questions that require an active response rather than a passive agreement. The circulating nurse and CRNA transport and verifies patient information when bringing the patient into the OR. This verification makes the nurses independently informed about what the physician should be doing during the procedure, so it almost creates a double check. And here's an example from our database of how these changes work to increase our ability to catch a potential event waiting to happen. Upon patient's arrival to same-day surgery, the operative schedule said right thumb partial amputation. The consent and HMP said right ring finger amputation. The patient and family were saying it was the right ring finger. Patient was held in an SSU until the surgeon saw the patient, and then the correct digit was confirmed and a site was marked and the patient was taken to the operating room. By referencing the relevant documentation and holding the patient until all discrepancies were corrected, this created multiple safety nets to catch human or system failures, and it was completely successful for this type of event. So let's take a look at the site marking. Some of the things we changed or reinforced is that our site will be marked by the proceduralist using reference documentation. It cannot be done by memory alone, and this is verified by another member of the healthcare team prior to the patient entering the OR, and this provides the double check of the site. Our surgical site marking will occur using the proceduralist initials. It was identified during the gap analysis that we did have variance in the way we were marking our sites. In our old way we used to mark, we would use the word yes, but we also had some that were using their initials. So the task force did make the decision that we would switch to all initials, and this has since been standardized throughout our system. Anesthesia now uses the word block to mark regional blocks, and a separate timeout is performed with regional blocks. Also, our marking is completed using a single-use permanent skin marker. By standardizing site marking, this allows the intended surgical site to be clearly identified by the perioperative team during the timeout. As we know, the timeout is the last line of defense that we have to recognize that a wrong site surgery is about to occur. So we reinforce that our timeout occurs after the patient is prepped and draped, and we added that the announcement of the timeout is assigned to the circulating nurse. This was discussed in much detail by the task force. We felt where we're at with our culture here at Excela, and that our circulators had a very firm grasp on ownership, and our nurse circulators agreed that they wanted to be identified as the leader who sets the tone in the operating room. They will hold other team members accountable to the timeout process, and they ensure that our team members are engaged and ready to perform the timeout. If the timeout is interrupted, then our circulators will call and have another timeout completed. A hard stop must occur by all members of the team. This means that all activities must stop. This includes everybody within that room, reps, students, everybody must stop. Team members need to be empowered to speak up for the benefit of the patient and provider if their knowledge differs from that of any other member of the team. Our executive and perioperative leadership team held meetings and set the expectation that the team was expected to speak up and they would be supported. This concept is supported throughout our team training. It's supported in daily practice by communicating respectfully, and we also practice these skills in simulation events. What did we change with teamwork? Well, recently I was speaking with one of our operating room managers, and she said something I thought was very relevant, and I wanted to reflect it here in this slide. She said that current operating personnel need to embrace a new mindset, and as leaders, we need to recognize that millennials are our future and represent the majority of the workforce today. Our millennials are innately collaborative, they're accustomed to learning in teams, and they want to have a voice, and they want to be recognized as providing valuable knowledge. So right now, our team members do introduce themselves in a role to the patient and to other members when they are brought into the operating room. Also, they serve as champions and share their knowledge and create a shared vision of why universal protocol is important, and they support members of the team. Working in our interprofessional groups to address patient safety serves to flatten our hierarchy and empowers staff to speak up if they have a safety concern. When you look at the elements of the timeout, really it's all about engaging the team. The team created a script at the end of every timeout, and it states, does anyone have any concerns? This is to encourage staff to speak up if they do have concerns. On this next slide, we wanted to show an example of why we have to keep pulling the team back together, which is a good thing, because after we had released our second policy, we thought we had a standardized process for site marking, but surgeons in the team were identifying that there were still some barriers in being able to consistently site mark technically or anatomically impossible or impractical to mark sites. We had a statement in our policy that just stated that decision would be made between the surgeon and the patient. And this team came back and said they really needed more clear-cut, a standard process, so everybody on that operative team knew that that was the site mark. So a standardized method has since been formulated. We are marking the dorsal surface of the hand on the side of the procedure, and this was agreed upon for alternative site marking for these types of cases, which could be urological and gynecological type of procedures. Listening, so really what this does for our team is that by listening and working to remove barriers that keep frontline staff from adhering to safety practice, this creates trust within our system, it supports teamwork, and it will improve our patient outcomes. So a question you might have is, do we think that our interprofessional collaborations made a difference in reducing the risk of wrong site surgery? I really believe it has, and here's why. First, we know that by examining near misses, we are provided two types of information. The first, we're provided our organizational weaknesses, such as our errors and failures. The second thing we're provided is our organizational strengths. These are our unplanned, informal recovery actions. And it's these types of strengths that compensate for our weaknesses on a daily basis, often making the essential difference between a harm or no harm event. By creating awareness that wrong site surgeries occur and that they're not the provider that caused it, but system issues, by empowering our staff to have a voice and creating a safe environment where staff can proactively report events leads to improved safety systems. We have to remember that the only thing standing between the patient and a wrong site surgery is the care provider, and we need them to report potential safety issues so we can fix our systems. So what are our next steps, and who else can benefit from what we've learned, and how do we improve? This past year, we've begun using the same process in interventional radiology as we outlined through this presentation. They have an interprofessional group that has sat around the table and talked about some of their barriers that they have in being able to mark or see sites in the interventional radiology department. We've had great engagement by the team thus far, and we definitely believe it's because we have all stakeholders, the whole team around the table discussing it at the same time. Also, our 30 near miss events for fiscal year 17, over 75% of them have been either booking errors coming in from our physician practices or from scheduling errors. And we've reached out and met with our centralized schedulers. We've engaged our management teams to look at workflows to reduce the risks of scheduling errors. And also we've started working with our physician practices out in the community, and we're reviewing our near-miss reports with them, reinforcing the importance of the role they play in reducing wrong site surgeries. Everything starts from the booking whenever that procedure or the intake is sent over to us. So we've really started an awareness program of what an important role they play and if there's anything in their workflow that can be adjusted to prevent some of these errors. So our takeaway for you today is that by developing an interprofessional task force, it opens up lines of communication between all members of the team, and this mutual respect creates a safer environment where staff feel empowered to speak up on behalf of patients and fellow colleagues to prevent wrong site surgery. As Henry Ford said, coming together is a beginning, keeping together is progress, and working together is success. Thank you for listening. I hope you found some of this helpful, and Lori and I will be happy to answer any of your questions. Kelly, I'm now going to turn the program back over to you.
Thanks, Jennifer. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of the program. Now we would like to begin our question and answer period. I'll start with the first one that was posed here. How did you get cardiologists to participate in pre-procedure verification? And maybe it's also a little bit about anybody that was kind of pushing back or not getting on board with a new initiative. How did you get those individuals to participate?
So I would say in regards to pushback that we've experienced, you know, we use I guess the saying, the cup of coffee type of discussion where we definitely saw it as educational opportunities. Because like I said, if you really don't have an awareness of how often this rare event is occurring, it really doesn't bring it down to that individual level that it takes a whole team to prevent these types of wrong site surgeries. So we would refer those to the appropriate level of leadership, and they would sit down and have discussions with those providers, and we just followed that process. Also, we did learn, that peer pressure does work pretty well in this type of situation, especially when you have an interprofessional team that's sitting around discussing barriers, and you have circulators, your nurses, and your surgeons all around the same table that, it's all about teamwork, and everybody has a role. And if you only have one or two of them that are refusing to do it and everybody else is embracing it, it almost makes them have to do it because then they're the outliers because the same message is being given to everybody at the same time.
That's some great information that I think a lot of organizations can embrace. Another person says great work, and I definitely agree as well. Have the interventions, for example, team training and education, been spread to all Excela hospitals? Also, did all staff, including surgeons, go through team training, and how long was the training?
Yes, we did expand on the team training and education. We had that in place prior to the task force being developed and kind of just made it an extra push for the peri-op group to attend. The expectation in Excela is that every employee attends, and it's approximately about a 2-hour program that staff have to attend. And like Jen said in her presentation, it's taught by members of the staff.
And that was actually something that we started. This was a long journey. I know that Excela had contacted the Patient Safety Authority probably somewhere around 2009 to do team steps training, which was where we started with a lot of this. And it has taken a number of years, but I believe over those years, almost every person inside of the system now has been trained in team steps, which really was valuable in a foundation for the wrong site surgery program.
And also on top of that, there are talks right now about creating a team training 2.0, where we're going to go back around and provide an update on education.
And I think Bob highlights a great opportunity. We're available as a resource as well. If facilities feel that we can be a benefit to help doing that education, please reach out to one of your patient safety liaisons or call our office. We would be glad to offer support in that. The next question is, can you tell us more about how you increase the number of near-miss event reporting?
So, I think a lot of this deals with the culture that we're creating, that, providing feedback. So what we do is when we receive our near-miss reports or even our events, we take those, we investigate them, we provide feedback to the staff. Also, we request feedback from that staff. So if they're seeing scheduling errors coming in, we're asking them where they're occurring. Is there certain trends they're seeing? We really want their feedback on how we can help them correct things coming in. Also, connecting the dots that, to the cycle of reporting of events. So the events come in, having that feedback, and then that leads to our prevention strategies that lead to our improved clinical outcomes. So it's about connecting the dots, transparency. There's multiple things that do feed into that.
Thank you. How do you address marking for sites such as the nose, tonsils, ears, otherwise those hard-to-reach areas?
That's where we use the alternative site marking. So because especially if there's laterality, we want to be able to reference that during the timeout. So if they're anatomically in position or if they would create embarrassment or leave any type of permanent type of marking, we do use our alternative method right now.
And how difficult was it to get buy-in of the circulators to lead or take accountability for the timeouts, and how did you overcome resistance?
Really, I don't think we felt a lot of resistance. Our circulators were very engaged. They were, and I think it goes back to they were part of the team from the beginning. And they very much wanted to make sure that, well, let's be realistic. Nobody wants to be in the room where wrong site surgery occurs. So they really wanted to take part in it. It was, pretty much their request to let them be the people that start the timeout.
And do you have a hard stop for surgical counts, or is it just specific to the timeout?
I know at the end of our case, we call a stop in for our counts. So I hope I'm answering that because I'm not clinical the whole way, but I have seen that we do stop for our counts.
Okay, there's a lot of great questions coming in, so I'm going to keep moving along as far as we have time. When you have multiple procedures within a surgery and different teams doing those procedures, like a fractured ankle after repairing an artery, different teams were brought in for these two different procedures. Who is responsible for doing time out?
We definitely have a timeout between all of those procedures. And when the team switches over, or if there is a change in team members, they do another hard stop, and it would be the circulator that calls for the timeout.
How do you get, and this question was already answered, and I don't know if you have anything to add additional. How do you get doctors to comply? And I think you kind of touched on that. I don't know if you have anything additional to say.
No, and it's basically feeding it up to the right people to address it. As you move through this, we have seen less and less resistance because, like I said before, it's a team, and once the majority of the team is on board, the rest of the people come.
I was surprised when we did observations at Excela. The physicians weren't shying away. Some had concerns, some asked questions, but they were all willing, and it seemed like there was real teamwork going on there, which is refreshing. I mean, I think they realize that wrong site surgery is an issue. It has been an issue for years, and we need to bring this to light. And it was great to see the buy-in, not just from the nursing and team, anesthesia team, but as well as the physicians.
And I think to Bob's point too, maybe to bring out is transparency. I remember when we first started our journey, we would go from one campus to another, and I would talk about an event that had occurred at the opposite campus, and I would get a lot of blank looks, like they didn't know something had happened. And you want to create that awareness because, and we've gotten pretty good at this over the last couple of years, is transparency is definitely needed because there are things to learn from every case. And if you're not willing to sit down and talk about them and find out why they're occurring and ask the 5 whys and improve your system, then they're just going to keep occurring. It's just a matter of rolling the dice. It's going to happen again if you don't fix the root cause of why it occurred the first time. So really it's that transparency that we do have them.
Can you guys identify what was your biggest barrier or challenge in moving forward with this initiative at Excela?
I think it'd be like, as we're looking at redoing our team training and our simulations, is resources of time and being able to get this group of staff members there, because as we know, a lot of pressure and time constraints with the amount of procedures that are going on. So that's probably been our largest barrier. And you have to have that executive and, our president of our surgical services really does devote a lot of time to ensuring that our staff's able to go, because without that, we probably would not have been able to move this very far.
Thank you. We do have one more question. And what is the one thing you felt empowered staff the most to speak up?
I think that's a hard one, because I could say it's focusing on the how instead of the who in these types of events. And I guess it's also walking the walk. So it's our interprofessional teams, with them being willing to sit and discuss barriers and not focus on ourselves and their needs, but focusing on what needs to be corrected to keep our patients safe. That does allow staff members to feel comfortable and safe about talking about the event.
One more thing before we go off. If anybody is considering consulting the Patient Safety Authority for help, it would be most beneficial. I mean, they can provide the resources and the time to help you with whatever the issues are, especially involving wrong site surgery. They are the experts, and we can't thank them enough for all the help that they gave us.
Thank you guys so much. At what point is the timeout done? Is it just before the doctor cuts, 1 to 2 minutes prior? Does the patient have to be draped, or just all pertinent people in the room?
I'll take that one. This should be done right prior to the surgeon being handed the blade. Too many times we see in our database a staff doing a timeout and then either going to scrub, prepping and continuing to prep and drape. It has to be done right before the physician is either handed the blade, before anesthesia staff or handed the syringe to inject the skin, and it should be done after the patient is prepped and draped. One other thing, too, is really important, is to ensure that everyone on the surgical team can actually see the surgical site mark. Can't tell you how many the events that we see where, for example, a knee arthroscopy where the surgical site or the surgical mark is made up on either on the thigh or down on the ankle away from the surgical site. You have to be able to see it inside of the actual surgical field.
Thank you, Bob. I want to thank everyone for joining us today, and our speakers. I think there was a lot of great information that you guys shared. Thank you so much. This concludes our webinar.